Good evening and welcome to everybody who's here. My name is Louise Irvin. I'm the co-chair of the Clinical Advisory Network on Sex and Gender, known for short as CANSG, and we're hosting tonight's webinar. The Pathways, Puberty Suppression and Transitional Care Study has received over £10 million in public funding from the National Institute for Health and Care Research. It will include a clinical trial of puberty blockers in children referred to youth gender clinics, as well as a longitudinal cohort study called Horizon. The puberty blocker clinical trial proposal has only recently been submitted to a research ethics committee and has not yet received ethical approval. In this webinar, we ask whether a clinical trial of puberty blockers for adolescents with gender incongruence, a trial of any design, could meet the ethical standards for clinical research in children and young people. We will hear from Dr. David Bell, who will introduce our two other speakers. This will be followed by a Q&A. If you'd like to ask a question, please post in the Q&A box on your screen. The chat function will be open, but we can't guarantee to be able to keep our eye on that. So if you have a question, please put it in the Q&A. Dr. David Bell retired from his post as consultant psychiatrist at the Tavistock and Portman NHS Foundation Trust in 2021. In 2018, while serving as trust governor representing the clinical staff, he authored a report that was highly critical of the Tavistock Gender Identity Service for Children and Adolescents, the GIDS. This report was part of the chain of events leading to the CAS review and subsequently the closure of GIDS. He is a past president of the British Psychoanalytic Society. Dr. Hannah Ryan is a registrar in clinical pharmacology and general medicine in the Northwest, with experience as a Cochrane evidence reviewer. Dr. Sinead Hellier is a registered nurse and clinical researcher who has considerable expertise in clinical trials. Dr. David Bell will introduce our two speakers more fully. Over 180 people have registered for this webinar. We will be recording it and putting it on our website. So over to you, David.
Thanks, Louise. Well, welcome to you all. And Louise has said a little bit about me and the others, and I'll say a little bit more. But first of all, I'd like to welcome you all. Few issues really in contemporary medicine have generated as much controversy as the case of medical intervention in gender-distressed children. And of course, the main medical intervention was puberty blockers. Our government, responding to the findings of the CAS review, has rightly banned the prescription of these drugs. And many other countries have now followed suit. It was a remarkable example, really, of the abandonment of ordinary, commonsensical, clinical attitude to patients and the invasion of a peculiar ideology, which seemed to lure people into a position in which they lost their ordinary clinical judgment. The government is looking to implement the CAS review's proposal for a clinical trial of these medicines to gather more evidence of their effects, subject to securing ethical approval. This raises a fundamental question. Can a clinical trial of puberty blockers in children experiencing gender distress be carried out ethically? And I would add, both ethically, can it be done ethically, and also can it be done with any kind of methodological rigor? I think the answer to this, upon scrutiny, is a resounding no. As a former psychiatrist, as Louise said, I was one of the whistleblowers who raised these concerns. And what we uncovered was a service driven more by ideology than any robust clinical reasoning. Many distressed children, often same-sex attracted, many with autistic comorbidities, were put on a medical pathway to transition by clinicians who have been captured by an ideology. And I'm sure many others, have seen the catastrophic consequences of this. That is, I've met many detransitioners who regretted their decision and felt that there was no real clinical inquiry as to why they wanted to, so to speak, be out of their body. So we're very concerned now that the plan to conduct this trial is really repeating history and conducting another experiment on children. So I'll introduce formally now our first speaker, and I'll introduce our second speaker after Sinead. So the plan is the speakers will speak for about 15 minutes or so, one after the other. We then might have a little to and fro between us on the panel, the four of us, and then we'll hand over to you, the participants, to put in the Q&A it doesn't have to be questions. It can just be points that you want to make or comments, and we'd like you to be, as free as you can. So I'll now introduce Dr. Sinead Hellier, registered nurse and clinical researcher. Sinead has considerable expertise in clinical trials, and she played a major role in authoring a statement. I helped her with it, but she played the major role in putting together a statement that's on our website. Her role requires a thorough understanding of research ethics. Sinead will talk about clinical trial regulations, ethical principles, as they apply to this puberty blockers trial. Central here is the fact that the proposed trial will be carried out on minors. I hand over to you now, Sinead.
Thank you very much, David, and thank you very much for everyone to come and listen to us today. This evening, as David said, I will outline clinical trials ethics and regulations. This will highlight how any clinical trial using puberty blockers, or I'll call them PBs through the rest of the talk, for children who present with gender dysphoria or gender-related distress is likely to be unethical and create an unacceptable level of risk to the child. Other avenues of clinical research into treating children with gender-related distress, which do not include medicating a child with PBs and that are safe to the child, must be prioritised. Before I start, it is important to note that other countries are also considering to use PBs within a clinical trial. The UK's CAS review has put the UK at the forefront of care for this vulnerable group of children. Therefore, any decision by UK authorities to authorise a trial of PBs for these children will have international ramifications. Medical clinical trials within the UK are governed by national and international codes of ethical conduct, regulation and quality standards. These were all founded by the Nuremberg Code in 1947. The key international regulations are the International Declaration of Helsinki and the ICH Good Clinical Practice. The key UK legislation here is the Medicines for Human Use Clinical Trial Regulations in 2004. These collectively instruct and regulate the inception, conduct, and governance of clinical trials to safeguard participants and ensure they are not harmed in the pursuit and development of medical knowledge and treatments. They must be adhered by all practitioners involved in clinical research. Principles and law regulating the conduct of clinical trials are far-reaching, but all centre on the prioritisation of the rights, safety, and well-being of the individual participants. They include to place significant focus on the protection of clinical trial participants, particularly vulnerable groups, for example, children. They must be scientifically sound at inception. They have to ensure the rights, safety, and well-being of participants, and that they take precedence over the interests of society and science, including the benefit or perceived benefit of any trial for society. They have to ensure that before a trial is initiated, any foreseeable risk are weighed against the anticipated benefit for participants in society. So, for example, there is a different risk-benefit calculation for a treatment that might be quite harmful or invasive, for example, to terminal cancer, compared to something for a common cold. So there has to be a clear risk-benefit. A trial must not be conducted where there is a clear risk of a disabling injury, and the trial must be for the benefit of society and unprocurable by other means. UK legislation stipulates that all clinical trials conducted must conform to these standards and many other standards. Children enrolled with any research programme by the NHS have legal and moral rights to these protections. In addition, UK legislation specifically states that a trial must be designed to minimise any foreseeable risk in relation to a child's stage of development. The CAS report is clear that norms of clinical practice to ensure the safety and effectiveness of care will be at the heart of any future services for this patient group. This is a very important and welcome step. It also means, in keeping with clinical trial requirements, the research and evidence-based produced to guide services must adhere to norms of these clinical trials, ethics and regulations. PBs may or may not be effective in treating gender dysphoria. The evidence base of the impact of PBs on gender incongruence, mental health, quality of life, for example, is of very low or low quality. Reports of high rates of suicide in children and young people who present with gender dysphoria, which is used as a key rationale for medical transition and PBs, are undermined by clear data and recent data, including a Finnish study, which highlights that the overall incidence of suicide in children up to youth aged up to 23 years presenting with gender dysphoria is equivalent to the general population once other mental health comorbidities are factored in. The authors of this report emphasise that diagnosis and treatment of mental health comorbidities, i.e. other issues that the child presents with, should be treatment of these should be the key method to prevent suicide in young people. There is thus no evidence base to support the presumption of benefit, which is a standard and necessary rationale for commencement of a drug-related clinical trial for children. Without this rationale, without this scientific rationale, that would normally halt any presumption of a clinical trial. In addition, there is clear evidence of harm. The first duty of any clinician in a clinical trial is to ensure safety. In contrast, any research proposal to medicate selected children who present with gender dysphoria with PBs as part of a clinical trial goes against the ethical demands and normal regulatory practice of such trials. There is evidence that it will cause harm to the children that such research is actually supposed to protect. The notion that the evidence base of the effectiveness of PBs could be determined in a carefully monitored clinical research trial is not congruent with ethical and regulatory standards. While such trials have a pivotal role in ensuring robust and high quality data to provide answers to important clinical questions, they first and foremost must ensure the safety and well-being of any individual child participating. That is, at the point of prescribing a child with PBs, we must be reasonably confident that the child will be safe and will not incur known injury, disability, or death. Given the known harms for which there is some evidence for, and harms that there is a reasonable argument for, the proposed research programme is unlikely to provide reassurance regarding this crucial matter. PBs have been used to suppress early onset puberty in cases of precocious puberty to then enable puberty to commence at a normal developmental phase or age. Conversely, for this presentation in gender-related distress or dysphoria, PBs are prescribed to physically healthy children to prevent normal pubertal development and human maturation. This is a divergence from normal clinical trial practice and of usual risk-benefit analysis of impacts on children who may participate in an NHS-supported research programme. As previously stated, the UK legislation safeguards child development within clinical trials. Here, in contrast, a trial would aim to interfere with child development as the key method of investigation. It is important to be clear. Prescription of PBs in the context of a trial would, in effect, introduce known and risk of systemic physical harm to a physically healthy child. There are strong grounds to believe PBs will, in effect, impact on the child's neurodevelopment with impacts on physical development. Current known and potential harms of PBs are multifold and include reduced bone density and early onset osteoporosis, brain swelling, and concerns around impairment of future sexual functioning and ability to form emotional relationships. A recent review of the impact of suppressing puberty on neurological function highlighted that adolescence is a critical window of neurodevelopment, and puberty plays a critical role in this process. The author concluded that suppression of puberty impacts brain structure and the development of social and cognitive functions, in which the effects are complex and often sex-specific. PBs may also lock in gender incongruence to medical transition, including cross-sex hormones and gender reassignment surgery. They also leave children sterile if administered before Tanner stage 2, which is quite early on, if followed by cross-sex hormones. Almost all children started on PBs progress to cross-sex hormones and potentially to surgical intervention, although the number of this is actually unknown. The prescription of PBs is de facto, therefore, starting a child on a medical pathway that will proceed to cross-sex hormones and potentially to surgical intervention, and is freighted with this knowledge and, of course, the ethical implications of that knowledge. Each of these factors would normally be sufficient in themselves to call a stop to any clinical trial from commencement, particularly in otherwise healthy children. Alternatively, if there had been unknown pre-trial and then came to light during the trial, they would be identified as part of normal safety monitoring and would be classified as a form of injury sufficient probably to close the trial. To commence a trial with these known and potential harms and outcomes goes against clinical trial regulatory and ethical practice, which seeks to protect from harm. In addition to the needs of the trial must be safe, evidence must be sought that must be unprocurable by other methods. This is particularly important with PBs, given the lack of quality evidence, the known and potential harms, and where there is no directly equivalent adult data to inform safety and effectiveness. Research should therefore initially focus on other methods of treatment before resorting to any pharmaceutical interventions, both to protect children and to generate an evidence base, particularly relating to potential harms. This is important when norms of adult data cannot contribute to the effectiveness and safety profile of PBs for children in gender distress, because of course the adults have already gone through puberty. Regulations suggest that this could include medical experimentation. For example, data on sheep demonstrates that long-term impact on spatial awareness post-cessation of PBs, intensive and long-term research into standard psychotherapeutic interventions, long-term follow-up of children who've already undergone previous PB medication, qualitative studies of the experiences of transitioners, and the full integration of current data, including safety profile of PBs when used for other clinical populations, such as prostate cancer and precocious puberty. These avenues should all be properly explored and analysed and assessed before any involvement of children in any other types of pharmaceutical study. In keeping with normal classification of clinical trials, any trial into the safety and efficacy of PBs in a new patient population and a new clinical indication, such as these are a new group of children who are physically healthy and the new classification is some form of gender distress, they would all be classed as a clinical trial of an investigative medicinal project, otherwise known as a CTIMP. This is important because a CTIMP provides tighter regulations regarding the safety and monitoring of any injurious outcomes, reporting as well as assessment. Importantly, in this context, children under the age of 16 are not allowed to provide informed consent in such a trial with such a classification. Consent must always be provided by a parent or legal guardian. The NHS England announcement of a developing of a clinical trial with PBs stated that they would require parental consent, which implies the study will be of this sort of classification. Parental consent in this context is highly complex, as such parents or legal guardians will be required to consent to the known and potential harms and potential sterility of their own physically healthy children. In addition, informed consent is at risk of being influenced by external political and cultural influences, many that would normally not be relevant in clinical trial consent processes, such as children's charities and human rights organisations who have publicly called for the active use of PBs for children who experience gender distress. These organisations often cite high risks of suicide if those who do not rapidly transition, but that is foundless because, as clearly identified by the Finnish study that I mentioned. Others have even unsuccessfully gone to the High Court to get the PB ban overruled. So in this context, it is difficult to see how assurances of valid informed consent and rights to withdraw, etc., without coercion can be achieved. In addition, within this context, differences in approach of gender dysphoria between parents who consent versus those who do not consent to the study could in themselves be an unanticipated confounding variable, particularly, for example, reports of child distress, anxiety, depression, body image, etc., are likely to be the sorts of reported outcomes that they're going to instigate. Because clearly by the support or the lack of support of parents may very well impact on these. This political environment, or this politicized environment, I should say, in which discussion of PBs for gender dysphoria sits within, indicates that we need to have even more caution before we bring in any sort of study. Ethical and ordinary safety concerns and clinical trial regulations underline the need for a complete moratorium on PBs, whether as part of a treatment program or in the context of clinical research. Proposed research should instead focus on the effectiveness of standard psychotherapeutic treatment pathways, follow-up of previous patients, etc., as I've already discussed, investigate the treatment pathways for the growing group of detransitioners, provision of further juvenile animal studies, etc., and the systematic review of the safety and impact in other clinical populations. All of this needs to be undertaken before any consideration of administering a pharmaceutical study to children. Thank you.
Thank you very much, Sinead. Could I just, before we go to Hannah, very, very briefly, I don't want you to talk expansively, but just to explain, I think, because it might not have been clear enough, but two things. One, what you meant by children being locked in. So if you could just say what you meant by that.
Yes, so effectively what we're concerned about is that the prescription of puberty blockers were originally considered to be given because they were supposed to give a child time to think or a pause in which to decide whether or not they wanted to go down the medical pathway of transition, or to actually think, yes, I'm going to grow out of this and actually I want to be the sex that I was born. However, that's not what's happened. All the studies that have shown, including studies that were done in this country, identified that once a child goes into a puberty blocker, they effectively get locked into the pathway of medical transition. So it does not act as a method in which it does not allow them to actually have the pause to think to decide against medical transition.
Yeah, maybe just to say that if you're very frightened of something happening and you don't get help with the fear, but instead you're given something to prevent it happening, it remains forever more frightening. So obviously you're going to want to stay where you are and not be exposed to that which we're so frightened of. The other thing is very brief, is just to remind us what CTIMP stands for, just
yes.
very, very briefly.
Yeah, so it's a clinical trial of an investigative medicinal product. So it's a bit of a mouthful, but it's called a CTIMP. And it's very important because if a clinical trial using a drug is classified as a CTIMP, then it has much stricter regulatory and safety processes. And as I said in my talk, that with regards to consent, no child under the age of 16 can consent themselves to a CTIMP. It has to be a parent or guardian. So Gillick competence does not factor in on this. Obviously, you need to get their opinion, but they can't consent. And the concern here is previous study that where children were medicated was not classed as one, and therefore they had much laxer safety profile, a much laxer safety regulatory regime, and also children were then left to make the decision about bringing themselves into such a trial.
Okay, thanks very much. Thanks very much, Sinead. So we'll now turn to Dr. Hannah Ryan, who's a registrar in clinical pharmacology and general medicine. She's experienced in evidence synthesis for guidelines and is the author of several Cochrane evidence reviews. Those are sort of very complex, big national reviews within the framework of evidence-based medicine. Hannah's going to explain to us why a sound scientific trial design is an ethical requirement in clinical research. I'll just say it again. She's going to explain why sound scientific trial design, maybe she's going to talk about what I was raising earlier about the methodological issues, is an ethical requirement in clinical research. Okay, Hannah.
Good evening, everyone. So I think I just want to acknowledge the complexity of this whole issue at the beginning, and just to say that I have changed my mind about this. I used to believe that a trial would help and that there was true clinical equipoise on this issue, and that it would help us to have a comparative trial. And I've changed my position mainly because I've learned a bit more about the condition. I've learned a bit more about the state of the field and the divergence amongst clinicians who are looking after children with gender dysphoria, gender incongruence, or gender-related distress, if you prefer. And so I think the way that I'm going to approach this is to think about the research question. And I also want to acknowledge that there is a protocol that's under consideration by a research ethics committee at the moment for the pathways study. So we believe that this is in the process of undergoing scrutiny by a REC. It will be interesting to see what that protocol actually looks like. But these are our sort of ideas and positions in anticipation of a protocol. And it may be that there are things in the protocol that surprise us, but I felt it would be interesting and useful to think about the research question and sort of break it down that way. So, so for a good trial, you need to have a good research question. And really the design of your trial flows from your research question. So you need to have a kind of clear and coherent hypothesis about a condition and an intervention and how that intervention helps that condition, and how you might identify, how you might measure how that intervention helps the condition. And I think we can imagine a question for puberty blockers that goes something like, do puberty blockers improve the lives of children and adolescents with gender-related distress? And you can complexify that question by thinking about, well, what does gender-related distress mean? What does an improvement mean? What qualities should we be looking to improve, and over what time period? And then the intervention. What does the intervention do? And what's our theory about how the intervention works? I put it to the group here that we kind of fail on every part of the question. We don't really know with any clarity what this condition is, if it indeed is one coherent condition. We don't really have a clear hypothesis as to how the intervention works and over what time period. And we don't know how to measure any kind of benefit. We don't know what measures reflect medium or long-term benefit on this question. So to start with the diagnosis, and really there are probably lots of people on this call better qualified than I to talk about the complexity of this diagnosis and the history of how this diagnosis has arisen. But just to go to the definitions that are presented in the Pathways Horizon protocol. So there's the Pathways study is a platform study, and there's already a part with an approved protocol for a longitudinal observational study called Horizon. And the way that they define gender incongruence, and they're looking at gender incongruence in pathways, not gender dysphoria, they say gender incongruence is a marked and persistent disparity between an individual's experienced gender and the birth registered sex, which may lead to a desire to transition, to live and be accepted as a person of the experienced gender. Gender incongruence may be more distressing during significant transitional life stages, such as adolescence, which can lead to gender dysphoria. And so they're drawing on the DSM and ICD definitions there. And really, are we really sure that we are clear that every child who's presenting with distress around their gender, or who identifies as the opposite sex or wishes to be identified by others as the opposite sex, are we really sure that we have a grip on what that condition is? We have quite a lot of evidence now that the epidemiology of this condition has dramatically changed over the last 15 or so years. The sex ratio has reversed amongst people, young children presenting and amongst adults. And from used to be young boys, now it's predominantly young girls. And there are a sort of rise in some comorbid conditions. So there are now more young people with autism spectrum disorders and other kinds of psychiatric or psychological comorbidity and experience of adverse childhood events, including abuse, presenting amongst the cohort. And this kind of raises questions about, well, what is really going on with these children? Are these children a kind of fairly homogenous group with a discrete condition that we can kind of clearly get a handle on and clearly describe, or are they actually quite a complex and heterogeneous group? And that matters quite a lot when we're thinking about performing a trial, because of course we have to think about how we're going to select participants for this trial and who we might select and who we might exclude. If we were going to exclude a lot of people on the basis of psychiatric or psychological comorbidity, it's likely that we wouldn't have a representative set of results for the cohort that is presenting currently. But then we might say, well, actually, it's very difficult to exclude those groups because of the issues around consent that Sinead's already alluded to. And so already at the very beginning of our research question, we're coming a cropper with what is going on with these children, and is this a condition that is really amenable to a clinical trial? So that's one point, and then there's the intervention. So puberty suppressants. When I'm talking about puberty suppressants, I'm talking about gonadotrophin releasing hormone analogues or agonists, and these are drugs that have been developed for other conditions. They've developed for prostate cancer treatment and other treatments, and we know very well how they work. We know very well that they're effective in their sort of biological, physiological effects, and they essentially block the hypothalamic pituitary gonadal axis, initially causing a hyperstimulation of the anterior pituitary and release of luteinizing hormone and follicle stimulating hormone, and then via negative feedback and desensitization, a kind of suppression of those hormones being released, and therefore a suppression of sex steroid production by the gonads in both males and females. And we know that they're very effective at doing that. They're administered as depot injections or as implants, so they're long acting, and they have well-defined safety profiles in the various conditions that they're licensed in. So we know quite a bit about the intervention and how it works. Now, this intervention was never intended to be given to children who are entering puberty at a normal time. So the adverse effects that they might have, or the on-target effects, the desirable effects they might have, have not been explored in a research context for this purpose before. So when we give them to children who are entering a normal puberty, what we're doing is shutting down the kind of complex process of sort of pulsatile release of GnRH that leads to the spikes in sex hormone production that drive the development of secondary sexual characteristics, as well as musculoskeletal development and metabolic changes, all sorts of changes that happen during puberty, neurocognitive changes that Sinead's already talked about. So this is a really complex and rapidly evolving kinetic process that happens in adolescence, and sort of ablating this process is likely to have lots of downstream effects. And the fact is that traditionally, for the last 80 years or so, we have privileged processes of development in childhood in research contexts, because we value non-interference with physiology and trying to minimize risk to developing children. And this is how this particular example, this particular situation kind of does step outside of the norm, because as Sinead said, we're using an intervention that we know very well will interfere with those processes. And while we might have only kind of partial evidence for their downstream effects in various ways, a lot of those effects are very predictable based on the mechanism of action of the drugs and what we know about puberty. So it's very predictable that if you suppress somebody's puberty at around Tanner stage 2, or probably before Tanner stage 4, you may well induce long-term problems with infertility and sexual function, particularly when you follow with cross-sex hormones. So that's the intervention. And then how would this intervention help with gender-related distress? So there are a variety of hypotheses put forward in the literature of how that might work. So one hypothesis would be pubertal development causes distress as you get the development of secondary sexual characteristics. And so the distress causes interference with social function and psychological health and possibly suicidality. Another is that these drugs can be used to pause development to allow more time for diagnostic exploration and identity exploration before any more permanent or irreversible treatments are given. Another might be that the long-term health and well-being in transgender adults is associated with better passing in the acquired gender, and intervention to prevent the development of secondary sexual characteristics promotes superior cosmetic outcomes, which enable passing. And then some people have hypothesized that you're preventing the need for particular types of surgery later on. So in males, particularly feminizing facial surgery, chondrolaryngoplasty or voice feminization, and in females, mastectomy. So you might not need those surgeries, or they might be less invasive. And then finally, you might make the induction of cross-sex hormones more effective at lower doses, possibly reducing the risk of dose-related adverse effects later on. And then I've also seen in the literature the idea that giving puberty blockers to children might stop them from seeking unprescribed treatments in an attempt to change their bodies. So give it to them in a clinical context or a trial, because otherwise they'll find it on the internet. So you can see that all of these hypotheses are carrying lots of assumptions. So firstly, the assumption that better passing in adulthood leads to a happy life and lower psychopathy, lower adverse outcomes in later life. The evidence for that is slim to none. So we don't really have clear evidence in adults that says passing is related to a better psychosocial functioning. There is some evidence looking at how passing is related to social affirmation, and some interesting observations about that. But there isn't a kind of clear signal that passing actually makes high social affirmation more likely or a better experience, and that this is directly related to superior psychosocial functioning. Passing is not really very well defined and is obviously a very subjective quantity. Then if we assume that, if we made those assumptions, we might say, well, passing well is therefore a worthy trade-off for lifelong dependence on exogenous hormones and risks of surgical interventions and complications thereof, and loss of fertility and other potential complications of puberty suppression, followed by cross-sex hormones. So again, that's quite an assumption. If you're balancing the benefit of passing well against all of those potential harms and some of those certain harms. And then we're also assuming that there are no other interventions or no interventions that are more likely to produce similar effects on adult psychosocial functioning in this cohort without the predicted adverse effects. So we're also sort of saying we're going to proceed with this because even though we know that it's risky and it has predictable harms, because we can't conceive of another intervention that might make this cohort happier and better functioning as adults. And I'm not sure that that's the case or that we couldn't come up with something else. So I think this question then, we've got a lot of uncertainty around the mechanism by which puberty suppression actually might help this cohort, and a lot of uncertainty around, well, what time frame are we really interested in? Are we interested in short-term management of distress, or are we interested in long-term outcomes in adults? And then, so that's the intervention, and then outcomes. So what outcomes could we measure in a trial context that might tell us something about whether this treatment is beneficial? So we might measure psychological distress, global functioning, symptoms of gender dysphoria, suicidality and self-harm. We might think about the number of participants who continue on to other forms of medical transition, participants who discontinue medical transition, metrics of satisfaction of appearance, passing, psychological functioning in adulthood, and subsequent surgical interventions. But most of those will be only measurable over the long term. The intermediate measurements that you might be able to undertake in a trial context within sort of 2 or 3 years, those don't carry any evidence that allows us to link them to adult outcomes. So if the idea in our question is actually we're just interested in short-term distress, then we might confidently measure that with psychometric tests. If we're actually interested in adult outcomes, we've got no proxy measures that have any evidence behind them that allow us to measure those in the trial and then say, well, we can confidently predict that these children will grow up to be adults that are happy with their choices and happy and functioning. So there's a big question mark there about whether anything that they measure in the trial that's proposed, which I believe will last for 2 years, will actually be useful in terms of telling us anything about long-term outcomes. So really, I think this sort of comes down to the balance of risks and benefits. I think the risks are significant. Some of them are near certain, just based on the way that this drug works, and some of them are more putative, such as the effects on neurocognitive development. But all of them make this a very risky prospect. There's also the fact that this cohort of children, we know from historic data that if you just did nothing and watchfully waited, a lot of these children would simply cease to have distress around their gender. And so I think that raises a big question as to whether undertaking a trial where we can't really identify the population of interest clearly, we can't predict and screen out those who will desist. We can't clearly characterize the mechanism by which the intervention might work, and we can't really define the outcomes that will tell us very much about whether it's worked or not and what will happen with these children in the future. I think given that context, I find it difficult to see how a trial could be designed to give us useful information about whether these drugs should be used in future for this indication. And I'll stop there.
Thank you very much. Louise and Sinead, could you sort of put your cameras back on now? I was just going to sort of not directly ask you a question. I've been looking at the questions while they've been coming up, but I had a number of thoughts. One was, why don't we stop using the term puberty blockers? It's a rather absurd term. The drug is a gonadotrophin releasing hormone blocker, and it's being used to stop puberty. But the drug is not a puberty blocker in the same way that an antihypertensive is defined by what it does. So I think that might be interesting. The The second thing, I wanted to say is just to bring the two of you together in terms of what you've said. That is that Sinead has given a very strong account of the ethical considerations in doing any trial like this at all, particularly on children. And one of those ethical considerations is whether it's methodologically feasible to do such a trial. And you've given us a very good account how it isn't feasible methodologically. So we're left with the sort of worry or great concern about why is it that these ordinary, you're both experts, but it also comes over as quite common sense. Why are these ordinary commonsensical and expert views just being put aside? And it does make one worry that it's to appease some other agenda and that children, in a sense, are being sacrificed to appease this agenda. So that's extremely worrying. One thing I was going to say as well is actually it's come up in one of the questions is I've noticed, that I've changed my terminology and I've noticed that you have too. We don't talk about gender dysphoria. Gender dysphoria sounds like a diagnosis. It's not a diagnosis. In one of Moliere's plays, I think it's a hypochondriac, he has one of the doctors, one of the patients say, I've been to the doctor and I had a pain in my joint, but now I know what it is. It's arthralgia. It isn't a diagnosis, it's just a Greek term for a pain in your joint. So that's what we do with this thing, gender dysphoria. We give it an elegant sort of Latin or Greek name as if it's a diagnosis. It's not. It's merely a description of gender distress. And one of the dangers, it seems to me, great danger of this trial, is to enter the trial, you have to have a diagnosis. By making the diagnosis of gender dysphoria, you're reinforcing it as a diagnosis. As Sinead said, you're locking the person in. Now, one of Cass's main points was that children with multiple problems were suffering what she called diagnostic overshadowing. That's once that diagnosis had been made, everything was viewed through that diagnosis. And that, although she didn't quite spell it out, it was clear from her report, that was a very, very significant harm done to children. So we're going to do it again with the trial. We're going to tell these children, you've got gender dysphoria. And it's particularly worrying, because a lot of our gay and lesbian colleagues have pointed out, a large number of these children are expressing their confusion and pain about sexual identity through gender identity problems. And so it seems to me, from what you've both said, it beggars belief how this can be seriously thought about. And I think I'll leave it there and we can bring in some of the questions, unless you want to respond to me straight away.
Well, I think you raised a really important point about, well, how have we got to this position when there are so many problems with this type of research? And I do think that there are political motivations for conducting a trial. And I also think that there are lots of well-meaning people who maybe just haven't thought through some of these ontological issues. Maybe another problem, as raised by an excellent recent paper by some of our Australian and American colleagues, is that there has been suppression of research and suppression of discourse around this topic within the clinical community. So when people are making decisions around funding research and how to commission research, who should be involved in research, then we only have a partial view of the range of opinions and ideas on this area from a look at the literature. So I think it's a reflection of the problems of the entire field that this has not been problematized in public, to put it that way, before the NIHR have decided to fund it.
Good. Do you want to say anything, Sinead?
Well, I just concur with what you've both said, but one sort of analogy that I think both yourself and David and I have discussed beforehand. It's the equivalent of deciding that lobotomies weren't necessarily a good idea and then just doing a randomized control trial just to confirm it. And that's effectively what I think is happening here.
Yeah, it's a very good example because there was strong so-called medical evidence for lobotomy that turned out to be no evidence at all. I mean, I'm just looking at the questions that have been asked. Some of them I think we've dealt with, like they can't, no trial can have credibility. There isn't a diagnosis. And Cass is saying that gender dysphoria is not a diagnosis. So many people, and we don't have the answers, but many people are concerned as to why Cass has agreed to this, why she put it in a report, and indeed why she is on the oversight committee. I don't think any of us know the answer to that. I think some people have raised a question about, I think it's one of the things you've tried to raise, is it's sometimes said that the harm that is being done, with the harm that is done to children who are, so to speak, really trans. So they're now having to wait by not getting their puberty blockers and so on. But of course, we don't think that we would never diagnose a child as really trans because we know there are multiple pathways to this disturbance. And calling them really trans, it becomes a self-fulfilling prophecy. But also there are children, of course, who present, say, at 14 with gender distress, and when they're 23, 24, 25, still want to transition. That's true. And what we do know, as far as we know, as current evidence suggests, this is a very small number. And what we do know, if we say that group A is the children who will persist, and group B is the children who will desist, that is, they'll change their minds. Group B is much larger than group A, especially if there's proper supportive psychological, psychotherapeutic intervention. So given there's no way of knowing if any child is in group A or group B, a blanket prescription of puberty blockers is going to do very, very much more harm. So we do know that. Can you see the questions as well, Sinead and Hannah?
Yes, I can. There are some
Is there
really
any question that you would like to take up?
I'd like to respond to Rianne Vogel's comment about what's going on in Norway. And I think she raises a really interesting point. So she says, how can moderate investments and applications be outweighed by the balance of risks and benefits of a new trial with new children? So she's talking about a situation where they're planning a new trial, despite the fact that they have high quality health registers that can be scrutinised for information about outcomes. And she says, I suspect that clinicians prefer to contribute to new cutting edge data to inform future practice, and perhaps a gradual reversal of practice based on new information over a very close look at the outcomes of the treatments that they have been providing and greenlighting until now. So I think you're right, Rianne. So I think there are incentives in medicine to do new research that's likely to be high profile, that will improve people's careers, that will give people greater kudos, and I think that yes, doing a clinical trial is much more high profile than going away and looking at some health registers and analysing that data. And yeah, I can only say, as somebody who mainly does research, secondary research, that yes, primary research is preferred and has a greater status. And there are things that you can only learn by doing primary research. But you're right that we shouldn't do primary research if we can find things out through secondary research, or at least we should do the secondary research first, so that we do very good primary research that's properly thought through. And I think that what's happening here is that we've got the cart before the horse, and there are all sorts of things that we should be doing before we do a clinical trial, including completing the data linkage study that, of course, Cass was unable to complete because of the non-cooperation of the adult clinics. So this is follow-up data from the children who already have received puberty blockers through the GIDS clinic. She actually went to the health secretary and had a piece of legislation put through to allow her to connect, well, not her, the research group who was performing this study, to connect the NHS numbers of those patients so that they could find out what's happened to them. And I think it's 8 out of 9 of the adult clinics refused to cooperate. And I'm not sure what the status of that study is, because and whether that will come to light. But I would have thought that the very least that we could do is wait for the outcome of that study and look at that data before we embark on a new piece of research giving GnRHAs to children.
Thank you, Hannah. There was a couple of questions I wanted to answer. One was, if the trial does go ahead and if the child later regrets it, who would be held responsible? Would there be a time limit for any claim? So all clinical trials require a form of indemnity. And I would think that really clinicians and researchers in this trial would have to ready themselves for the possibility of future litigation. I can't see any other way out of it. So there is that. With whether or not there's a time limit, I don't know. But of course, we have in the press with regards to the blood transfusion scandal. Part of that was a clinical trial where they gave blood to children, and children then developed HIV and other forms of hepatitis, etc. So that was sort of 20, 30, 40, 50 years ago, and they still can actually claim. And I think family members for those have died. So I don't know the specifics, I have to admit, but I think it would be very likely that they would be able to have a claim against them. Another one was about, since it's so unethical, why did CAS recommend it and how can it receive ethical approval? On those, but both those questions, I don't know. It seems incomprehensible to me. But the law is quite clear in this country that you cannot sort of put at risk a child's stage of development. If you know, in a healthy child, you know, the risk benefit calculation does need to take account in the circumstance, and the child is healthy. So I don't see that there's any rationale for that, and the law does protect the child. While the law is not being brought in to protect the child in this context, I've no idea.
I'm just to get some of the other questions. Will the ethics committee decision, whichever way it goes, be made available to the public to read? I don't know the answer to that, but I expect that anything of that seriousness should be a public document. Does anyone know? Don't know.
I mean, the outcome will be publicly available.
No, but yeah.
The detail of their decision making, you might have to FOI, but it shouldn't be a secret for any reason. And it will be interesting to see what they say about it. We don't know whether they've submitted a randomized controlled trial design or any other type of trial design. CanSG has been writing to the Health Research Authority about this, anticipating the protocol going to the Rex. So we have had some dialogue already with the HRA, but we're just waiting now to see what happens. And I think that there are a few questions in the chat about, well, what do we do? What can be done if this trial receives ethical approval? It also has to have regulatory approval. So it also has to have approval from the MHRA. So I think we do have to make representations to the MHRA, to the HRA, and you know, to political representatives as well about it. I think there are already people who are thinking about a legal challenge as well. Certainly CanSG will be making representations to the regulators around this, well, continuing to do so. Another question about...
Sorry, Hannah, do you mind if I just add on to that?
Oh, yeah, go ahead.
So the clinical trials are supposed to be transparent. So whether or not they actively publish the details of the ethics decision, I'm not entirely sure, but you should be able to FOA, as David has said. And it's also important to remember that the sponsor, so that's King's College London, and I think it's the South London and Maudsley, it has to go through their ethics committee as well. In addition, any hospital in which children are recruited from, that it has to be approved by them as well. So although you've got the regulatory approval from MHRA and the ethics committee, as Hannah said, there's numerous ports in which needs to be written to and to complain, because all of them actually have to have their own individual steps where they have to approve it from their own organizational perspective.
Good. That helps, because some people are asking, what can we do? And that's one thing you can do. You can, if you think your health authority is involved, you can ask them if they are, and you can ask to speak to their ethics committee and make a representation.
Maybe we should,
sorry, Hannah.
Maybe we as CanSG should put something online about a sort of guide to who you should write to. Because it's multiple different people and organisations. I'd like to. Paul Garner's made a point about supply and demand. So he said, these medical pathways are demand-led, yet all the government is doing, and also us in CanSG, are working on the supply side. Should we or some other group be working intensively on the demand side? I think he means. Otherwise, we just talk within our own silos. So I think that's a point about strategy, and I think that it's a challenge, isn't it? Because this is one of the really big problems with this field, is that the diametrically opposed views, and even people with more nuanced views, are not in dialogue about how to proceed, which is leading to people taking ill thought through steps in terms of new research, and being led by political agendas rather than by a scientific rationale for how you should proceed. And I don't know what the answer to that is. We held a conference a year or so, more than a year ago, that was vigorously and enthusiastically protested against, including by other clinicians. So I'm not sure how we do that. I think there are lots and lots of groups who are trying to amplify the voices of patients who have been harmed by these treatments, either as adults who continue to be trans-identified or as detransitioned young people and adults. I think those voices are incredibly important. And I think that there are sort of several lines of reasoning that we need to continually challenge. So because it's not just one, there's not one kind of magical winning argument. There's this entire construct is full of sort of paradoxes and assumptions about the causal relationships between properties, and there's sort of question marks over lots of parts of this problem in all of the age groups, and it's not apparent to me why we should be intervening with the physical health, particularly of children and young people, to treat a problem that some even say is not a problem. It's not. It's just a manifestation of some of the range of normal, and the sort of rising number of young people who are identifying neither as a trans boy or trans girl, but as a non-binary young person. That identity label and its associated labels really challenge us to sort of think, well, how does that kind of experience justify medical intervention?
Yeah.
And the literature, unfortunately, increasingly is making arguments for medical intervention in children and young people, well, at least young people who identify as non-binary. So
we can link that a bit to two of the questions, I think, because one person was suggesting that why don't we understand these people more, understand people who present as we would call it with gender distress. How did they get there? What are the pathways? What happens to them? How many of them go on to transition later in life? And if they do, what happens to them? That's what we would call a naturalistic study. That's not involving any intervention, and we would absolutely support that.
Yeah.
And that's the information that we don't have. And that information would take a long time to gather, 10, 15, 20 years even to know. So, but it's very, very important question that has just been put aside. And then someone asks, how can you detransition if you've been on puberty blockers? Well, the question there is that, when I was involved in this, it was said that puberty blockers are reversible. And this is not true. It was a false statement made by clinicians and by the CEO of the TAVI. What they meant was that if you stop puberty blockers, puberty occurs. That's correct. But that's not saying something is reversible, because the human mind, body, and so on isn't a video recorder that you can press pause and then restart. Because what you've both been saying, and obviously I agree with and Louise agrees with, is at a certain point in life, the brain, the body, the psychology, and the social situation of a child is ready for puberty. That's a very different thing to having puberty when you're 18 or 19, but also there's strong evidence that delaying puberty causes cognitive problems. The evidence isn't from humans, it's from animals, it's from animal studies. But if you were a parent and you knew that stopping puberty, interfered with cognitive development in rats and sheep, would you be saying that's all right, try it out on my child? So that's very strange too. The other thing is about detransitioners. Related to each other is that in any case, as Sinead has said, going on puberty blockers locks you in. I think it's a little bit like saying to an agoraphobic person, right, you're agoraphobic. The treatment used to be that we gradually expose you to going out with help from a clinician or a nurse who can take you a few steps down the street, and then we'll go home and we'll gradually try and battle it. We've got a new treatment. You never have to go out. And then we're going to measure the treatment in a year to see if you feel better. Oh, yes, I feel much better because I'm not going out. Everything is brought to me now. And that's the kind of thing you're doing with the trial. That, if you put them on puberty blockers, people will feel better because they're phobic about puberty. But you're not treating why they're phobic about puberty. So it seems to me very strange. And of course, the detransitioners that I've met, you're quite right. Because 98% go on to opposite sex hormones, and no one knows how many go on to surgery. We know it's a substantial number because the Tavistock never, ever followed up these patients. We do not know. They did an experiment with no follow-up. The judges in court were appalled to hear this. So now we do not know what happens to these kids who go on puberty blockers, then opposite sex hormones, and then surgery. But we do know that those who have surgery regret, you cannot reverse it. The voice is irreversibly changed. You can't have breasts back after they've been removed. You can't have pelvic organs back. So you, as one detransitioner put it to me at a conference, I am not a man. I am now a deformed woman, and there's nothing I can do about it. But now that's what I have to live with. And another one said, I represent a generation of young people who are robbed of the capacity to have an imagination. That is, they had these ideas and the culture around them said, oh yes, you're trans. And they've suffered for that. So we've done considerable harm to generations of children, and we're about to do it again in a clinical trial.
If I could add, because it reflects to some of the questions that have been put into the chat. I think one of the reasons why people are so keen to do the trial is because it's the avenue in which to give puberty blockers again. So the avenue which puberty blockers were first brought in this circumstance was through a trial, and they're just repeating what happened beforehand. And I think that probably partly feeds into what David's point just a moment ago about that they didn't do any long-term follow-up. And I think a lot of it is because they weren't interested in the long-term follow-up at all. They just wanted the puberty blockers to be given to the children. So I think we really are, as David said, about to repeat something which should never been completed in the first place.
Can I also just add that I think in the context of a ban on prescribing puberty blockers for gender dysphoria, the concerns have been raised by those who support their use, that this is a kind of form of research coercion, that you can't get these drugs any other way. So people who otherwise might not have taken part in research will now be keen on taking part in research. And I think that there is a kind of paradox of we might support a ban on puberty blockers, but actually it does raise problems with conducting a trial. I think that's a valid point, that this is a form of research coercion for those who are very, very keen on having puberty blockers. I think that it also will interfere with possibly interfere with the results of the trial, because it will include only children and families who wish to have puberty blockers, for one thing. So those children who are ambivalent or their parents are ambivalent will not be included in the trial. And then you will have a group of children, if you have a comparative trial with a control group, which would be the only real reasonable way of proceeding, then you'll have your intervention group who get their puberty blockers, and even if there's initial blinding, after a few months it will be apparent that they have had puberty blockers. And they'll be very happy, and they'll have obviously lots of placebo effects associated with being in a trial and having the intervention that they desired. And then you'll have your control group who will realise that they haven't had their intervention that they desired, and will be terribly frustrated and disappointed, and may experience some nocebo effects. And so if you measure both groups measure their various psychometric measures of social functioning, happiness, satisfaction with their appearance, and gender dysphoria metrics at your intermediate follow-up point of 2 years, then you may well see a difference. There may be a significant difference between the groups, but would that be attributable to puberty blockers? Well, no, I wouldn't think it would be. It would be principally attributable to placebo, that's augmented by the surrounding circumstances in the clinical environment and the social environment. I just also wanted to respond to Lenny Cornwall's question: would the same considerations apply to a trial of any psychological therapy for gender dysphoria? There would still be the issue of defining the problem and defining an outcome. So yeah, I think yes, there would be problems in how you're going to which young people you're going to include, how you're going to define the condition, how you're going to what your sort of metrics that kind of indicate success. I think the difference there is that the risk benefit is not so hideously skewed. So your intervention hopefully is much less risky, certainly to their physical health, and so you can you might feel a bit more comfortable with some uncertainty around the sort of characteristics of the condition, and the fact that you've got a lot of subjective outcome measures. I think it would still be difficult. I think it's not my area of expertise at all, but I think most trials of psychological therapies are quite difficult. It's a complex intervention. But I think the difficulty with puberty suppression is that this intervention, we have no real kind of clear idea of the mechanism by which it would help, and also it's just so very risky. So so yeah, I think some of the same considerations, but maybe not the same risk benefit ratio, to put it that way. What do you think, David and Sinead?
Sinead?
I think that's the crux, isn't it? The reasons to go for psychological therapy beforehand, yes, there are risks associated with that, but you are not physically harming a child, which there is known and long-term and risks to that. So the risk benefit has to be a calculation on how you proceed with something. And equally, with regards to psychological therapy, if a child is distressed, then that is the normal sorts of therapy that you provide. So you actually have a undercurrent of scientific evidence that actually it might work. So you have a justification for it. But as you say, with puberty blockers, there is no justification for it. We have no evidence to suggest it works, and particularly with this much more expanded cohort of children.
I'd like to come back because it's come up as well about parents. I've talked to some parents, and one of the things that's quite evident is that if your child suffers from, quite serious psychological problems, it's a terrible thing for a parent. All parents, even if there's no reason for it, feel guilty. They feel, what have I done? That's quite normal and needs managing. And sometimes there is something the parent might have done at some time, but now they feel it's come home to roost, some event occurred or whatever. So when the child, as one person put it to me, says, I've gone online and I'm trans, that's the problem. It's a kind of relief because you think it's not me, it's not something in the family. It's they've got this physical condition, they're in the wrong body and the doctors can treat them. So there's then an understandable resistance to changing that position because the fear is that you'll start feeling implicated, guilty or whatever. So parents can easily find themselves drawn into siding with the idea that this child is trans. And some of them, of course, for various other reasons, might become quite militant about it. So the relationship between the child and the parent is complicated in that way. Secondly, what was I going to say? No, it's gone now. It's something to do with parents and children. But oh yes, I know what it was. The way a mother put it to me was this. She said, "I don't know what to do. Let's just call the child Rebecca. She tells me she's a man. I can't tell her she isn't. It's just terrible at home." But then she said, "But the great thing is, there's a child psychotherapist. I think it was a child psychologist who sees Rebecca, and she doesn't side with her. She doesn't oppose her, but she doesn't side with her, and she explores it." So when Rebecca complains to me, I can just say, "Well, talk to the psychologist about it." In other words, the parent needs a third person who can take up a different position. The child can get angry with that person and so on. But when it's just left to the couple of the parent and the child, it's very different. But they need to rely upon someone. And if someone says, "Oh yes, good, go on a puberty blocking trial," the parent will feel let down, but won't be able to oppose it.
I think that's really important. And then that brings in the issue about informed consent, because that's not consent, that's coercion, that's part of the problem. So a number of the questions have sort of inferred this, but there will be numerous parents who would be very, very keen for their child to enter the trial, and there'll be lots of parents that would refuse for their child to enter the trial, and there'll be that group of parents who don't want to but actually feel that they need to be coerced, and all of that underlines the sort of the lack of full informed consent for everybody, but also it then mitigates the outcomes and brings in sort of confounding variables because they will all impact on how the child feels about themselves. And then just another point which was brought in, which sort of brings in, David, your point about parents, is somebody brought up the issue regarding the focus of other sorts of similar bodily interventions such as FGM, etc. And
Yes,
again, the fact that we don't look at this in exactly the same way, I think is really, really problematic.
Yeah, I absolutely agree with that. Helen Daly has said that, I think she said that some hospitals have refused. To be helpful to know about that, which hospitals they are. And I think she said something else, but I can't remember what it was now that was helpful. Yeah, she said some teaching hospitals already said they will not take part in a trial. So that'd be very interesting to know. There was something else. I'll just find it. No, I can't find it now. Oh, yes, I know what it was. It was that, as I said, it's quite a subtle and very, very profound point, I think, is that if you are saying we are going to do a puberty blocking trial, you are saying it's okay to give puberty blockers to children. And once you say that, then children will say, well, look, the government is doing a puberty blocker, or people will say, or family members, so they can't get them on the NHS. We don't want them to go on a trial, so we'll just get them online. So you're actually promoting the possibility of loads of children trying to access puberty blockers online and parents having to say, well, if the government think it's okay for children to have them on this trial, how can I oppose it? That's a very, very important.
I think it's even more sort of subtle and complicated than that, isn't it? Because we know that there are still children trying to access these drugs and sometimes successfully accessing these drugs through overseas prescriptions and things like this. And it's actually very difficult for government to close those loopholes. That it does endorse this as a possible treatment, and I have heard from psychologists who treat this cohort say, well, actually, one of the big problems in GIDS was because this treatment was there and there was a high demand from many of the children for this treatment, that actually stymied other types of treatment or even assessment with the psychologist because they were just acting as gatekeepers for the drugs. And of course, this actually completely replicates that scenario where if the family and the child are keen on puberty suppression as their sort of first line treatment, then they'll be doing and saying whatever they want, whatever they think they need to do to get into the trial. And they may not be as interested in other forms of identity exploration or psychosocial support. And so we're really possibly doing harm in other ways, in inadvertent ways, by continuing with the trial. I thoroughly agree with Paul's point. Paul says that doing an RCT in this circumstance, doing an RCT in an ideologically driven area will be a disaster. I believe that's true, and I think that we will see if the trial does go ahead. I don't believe it will yield an outcome that will settle any questions, and I believe it may have to stop because it's either unfeasible or it becomes very obvious that it's unethical.
Yeah.
So we don't know what will happen. I think it's good that people are asking for ways to challenge the status quo. And Paul, I hear your impassioned plea that we need to get information to parents and young children in other ways. I think that's a valid point, and we really need to be thinking about that. And sort of challenging the assumptions that are made underneath sort of quite blandish statements about what this condition is and what are the important outcomes. And I think there's a lot of unpacking to do when the protocol is published, if it's published.
I was thinking as well that it's a small point in a way, but I don't like the term comorbidities, because if a child is presenting with gender distress and anxiety and depression and social dysfunctioning and some cognitive difficulties, these aren't comorbidities. It's not like having hypertension and arthritis which might not at all be related. That's a comorbidity. But Freud once argued that every problem a person has is connected to everything else about them. There aren't lots of different problems. So I think this comorbidity is wrong, that these are all manifestations of the suffering and distress of the child, and it manifests as anxiety, as this, as that, and also as gender distress. So I think that's an important point, because even calling it a comorbidity is saying that gender distress is a definable thing, and it isn't. But we're coming to the end. Sorry.
So just one point on that, the whole distress thing. If you look at some of the more recent data that's coming out, so Joanna Olson-Kennedy's puberty blocker study that came out recently, that she was very reluctant to publish because it showed no benefit. She sort of says, well, they were fine when they went into the study and they were fine when they came out the other end. And it's very interesting. She selected a group of children who were very keen on, living as the opposite sex, whatever that means, but were not very distressed. They'd had undergone early social transition, so often social transition before the age of 9 or 10, and they had been surrounded by a kind of social milieu in which they had been affirmed in the parlance, in their preferred gender, and then they had undergone puberty suppression, and they weren't suffering a great deal of distress. And you can sort of say, well, really, what are we doing this intervention for then? It really is about downstream effects of these drugs, and
anyway, the time span of the study makes it irrelevant anyway.
And the people that promote these drugs are not actually very honest about what these drugs are doing, or what they think these drugs are beneficial for. And I think that's a crucial part of all of this, is that the people that promote these interventions have changed the goalposts so many times, and you can track this through the literature. I think if this trial goes ahead, any results will be leveraged for or against in exactly the same way as all of the observational data has.
Thanks very much. Well, I think we should draw to a close now. I think we should hand back to Louise to maybe you've got any comment that you want to make. You've been very patiently listening and not said. I think we've got some interesting things to take back, particularly about how people can be active in this. So, and I hope we can save these comments because they've been really terrific and interesting and helpful to us. But I'll hand over to you now, Louise.
Thank you. Thanks very much, David. And thank you, Sinead and Hannah, for an incredibly interesting and thought-provoking discussion. And thank you to the participants, because you've asked really good questions. I've tried to answer some as well, typing away as people were talking, but there are some that still haven't been answered, and if we can do so, we will try to answer them, perhaps put them on our website, and do so that way. If you want to find out more on our CanSG website, we'll have the recording of this webinar, but there are also links to articles we've already written about this issue, and also an article where we've listed all the many organizations, regulators, sponsors, funders, trialists that we've written to, raising our ethical concerns. And the interesting thing is that very few of them have bothered to even reply to us, even though we put detailed arguments, as you've heard today. And one or two responses have just brushed us off as if this doesn't matter. And the Health Research Authority has said they will log our letter as a complaint that will go to the research team once the research has received ethical approval, which seems to me a bit of a strange way to go around about things.
Yeah,
I think what Sinead was saying, that there will be other stages this will go through, even after it gets ethical approval from a research ethics committee, if that does indeed happen. And it's interesting how delayed it's been. I think they're really struggling. It was also, they were supposed to have started recruiting for this trial in the spring of 2025. So the delay suggests to me that they're struggling. But even if it does get Research Ethics Committee approval. It still has to be agreed by the MHRA. And the organizations that will be recruiting children to it will have to have their ethics committees will have to agree. So I think there's opportunities for us to write to all of them. And I'm going to put details of that on the website when we do a summary of this webinar, so that people can just, anybody who feels concerned about it can write individually. Somebody said in the chat, wouldn't it be easier just to do a legal challenge? Well, first of all, I don't think legal challenges are necessarily easy or easier, but it doesn't mean that you shouldn't do everything. And in fact, I don't think you can really it would be hard to get a judge to agree to a legal challenge unless you've shown that you've done everything possible to raise the concerns through the legitimate channels. And it also gives them a chance to see just how much public concern there is. And that might be, everything does, unfortunately, things like that kind of pressure, do make a difference. And we can bring that to bear. So sorry, I'm talking too much. Yes, I will try and put something on the website. On our website, you can also see a way of signing up to our newsletter, and you'll get news of future webinars. We're planning, just in the early stages of planning now, a webinar on gender affirming surgery, in particular the impact of what's called top surgery, euphemistically, which is double mastectomy, which is more and more happening to women under the age of 25, and there are implications for later life when some of them have children and want to breastfeed, and there are some studies of long-term regret. So I think we'd like to look at that issue. And the other one was mentioned earlier, the difficulty of getting it published. Any research that challenges the dominant narrative about so-called gender-affirming care, difficult getting published, difficult getting funding to do research, and that's led to a kind of imbalance in the evidence and the discourse on this issue. So we want to do a webinar on this and have some of the researchers who have been struggling to get funding or to get published. So these are ideas for the future. But for now, I'd just like to say thank you once again to you, David, and to Sinead and to Hannah, and to all our participants for what's been a really very interesting webinar. So thank you and good night.
Thanks.